Welcome to Dr. Jeff Talks About Sex and Intimacy, the podcast where we explore anything and everything relevant to sexual health, relationships, and intimacy. Thank you for joining us today live or on the recording for episode 39, Breaking New Ground. What's new in sexual medicine for men and women? Thank you for being here with us. I am truly so grateful for each and every listener. You are what this podcast is about, and you are why we exist. So thank you. I want to remind you that it is Prostate Cancer Awareness Month. I've been doing this each week to remind you, and I just want to take a minute to acknowledge the many brave people out there living with prostate cancer and who are prostate cancer survivors. You are true heroes, and it has been an honor and a privilege to be a part of your healing journey. So thank you. And you see, I have my blue on again tonight, and that is because it is Prostate Cancer Awareness Month. 1 in 8 men are affected by prostate cancer. And although 98% survival rate for 5 years, sexual dysfunction is the number one long-term complaint, whether a man is treated with surgery, radiation, or androgen deprivation therapy. So this podcast is always for those men out there who are struggling with sexual dysfunction and those amazing prostate cancer survivors. Thank you for being who you are and the heroes that you are and paving the way for others. We're out there on social media. We're on Facebook. We're on YouTube. We're on X. We're on LinkedIn. We're on Kick. If you're on X and you have a question, you can go to LinkedIn, Facebook, StreamYard to allow you to submit your questions. But we're so excited. However you're here, we're really glad you're here. Please go to the website to watch previous episodes. There's 38 of them, and we have some of the most amazing guests and great topics for you to learn. And I hope you will go to that website to learn about that. You can pull up the calendar and see what's coming up next all the way through the end of the year. So go to the website to learn more. Listen to us while you're working out, while you're in the car. We are on your favorite music streaming services like Spotify, like Amazon Music, iHeartRadio. We're there with you when you're working out, when you're in the car. You can learn about sex and intimacy. I want to take a minute to remind everyone, as I do each episode, that everyone is welcome here. All are welcome. You are welcome, whatever your sexual orientation, whatever your gender identity or your relationship style. We are so happy you are here, and you are truly welcome in this space. So this podcast, what's it all about? The goal of the podcast is to empower you and enlighten you with scientific, evidence-based information, good, accurate information that you need to improve your sexual health and deepen your relationship so you can live and you can love this miraculous life you have more fully and more wholeheartedly. That's all this podcast is about. Today's episode, I am really excited about today's episode. It's all about breaking new ground in the world of sexual medicine. And I'm telling you, from the first time I stepped into this arena decades ago, our speakers today are the people who are the movers and the shakers and brave enough to move us forward with wonderful new research. So I couldn't be happier. We could not have better guests than we have tonight to talk to us about what's new and exciting, because these are the true pioneers of sexual medicine. And I am so excited that they are here. Advances in science and treatments are opening up possibilities we couldn't have imagined a decade ago, from innovative therapies for sexual pain and desire to new novel approaches for erectile dysfunction and arousal disorders. We're talking about what's on the horizon for men and for women and what's already changing lives today. To guide us through these exciting developments, I'm joined by two of my friends and colleagues and truly the best pioneers I know out there in sexual medicine, Sue Goldstein and Dr. Irwin Goldstein. They are truly moving the frontier forward. Now, Dr. Irwin Goldstein is a pioneer in sexual medicine, serving as the director of sexual medicine at the Alvarado Hospital, and he's also the director of San Diego Sexual Medicine, which he founded. With over 4 decades of clinical research and academic leadership, he's been at the forefront of understanding and treating sexual dysfunction in both men and women. His work has advanced therapies for conditions such as erectile dysfunction, low sexual desire, and sexual pain disorders, and he has helped shape the very field of sexual medicine as we know it today. And that is honestly understated, if anything. And then his amazing wife and partner, Dr. Sue Goldstein, is a highly regarded sexuality educator and clinical research manager at San Diego Sexual Medicine. With a background in education and counseling, she specializes in helping individuals and couples navigate the emotional and relational aspects of sexual health. She has co-authored several publications and books with Dr. Irwin Goldstein, her husband, and has been a strong voice in advancing sexual medicine education for both healthcare providers and the public. Together, Sue and Irwin Goldstein bring a unique combination of medical expertise and human connection to their work, changing the way the world understands and treats sexual medicine. Truly, I could not be more honored to have these two guests today, and I'm telling you, they are the people when it comes to moving forward as sexual medicine. So welcome to both of you.
Thanks, Jeff. I just want to point out we're both wearing blue as well. So please, this is National Prostate Awareness Time. So pretty soon it's going to be Movember, and you can all grow your mustaches.
Yeah, that's for sure.
We are so thrilled to be sitting across the table from you, Jeff. And just for those people around the world, we're actually going to see Jeff pretty soon at a conference that we all belong to. So we're excited to give you a hug when we see you in person.
Hey, Jeff, I remember back to the days of Levitra, and we had this premonition that advanced providers should really get involved, and the people of note said you were the person, that you became the leader, and it was kind of an advanced concept to get involved with advanced practitioners, and I have to say that was truly a fun experience, and that's literally 25 years ago, 24 years ago, something like that.
Yeah, we're definitely dating ourselves. But yes, you're so right. And the thing that's so amazing and why I'm so excited you're here is we share a passion for helping people have fulfilling sexual and intimate relationships, because what could be more important than love and relationships? So I think it's great work we get to do, and I'm so excited to hear what you guys have to say. So without further ado, I'm going to hand it over to you.
Thank you. I think in order to appreciate where we are now and where we're going, it's always good to understand where we came from. So that picture of Irwin and myself was taken 53 years ago. We're married 51 years. No, it's more than that. But anyway, this sort of, we're reaching out to all of you. We have been married for a long time. And I always tell people I'm married to my best friend and we're still having sex. So intimacy is definitely something that's important.
Jeff taught us how to do this.
Maintaining a relationship. But I'm going to fly through a little of the background. But first, just as a disclaimer, we're going to use the word women and female and men as male. And we recognize that not everybody born with female genitalia considers themselves a female, and vice versa with male. So we're going to just use those words for ease of term. But we're referring to all people and however they identify themselves. So sexual medicine really goes back to Kinsey's time, when he did the first epidemiologic studies in 1948, got well funded by Rockefeller. And in 1952, when he did studies in women, lost all that funding. So this is where it's not much different today. You've probably heard of Masters and Johnson, that really were the initiators of modern day sex therapy. But at that time, in the 60s, the thought was that the only people who had a biologic problem for erectile dysfunction, which was really the number one sexual dysfunction at the time, it was from a prostatectomy. Otherwise, it was considered psychogenic.
That's considering it's prostate cancer awareness.
Yes. So literally. Now, the 1970s, we had the development of the implant. So we could put an implant in a man who had prostate cancer and had erectile dysfunction, but they still didn't understand what was going on. The other thing in the 1970s is they did penile revascularization surgery to literally bypass a fracture and restore normal sexual function to a young man who was otherwise healthy. So those were big steps in the past. But it wasn't until the 1980s when this man you see in the picture, Giles Brindley, injected his penis with a medication that gave himself an erection, that the world understood how erections worked, that it wasn't posters with smooth muscle relaxation. And for the first time, we recognized that erectile dysfunction could be a biologic problem, and we now had a biologic treatment other than surgery, putting in an implant. And that was 1983, and we still continue to do injection therapy for men. In the 1990s, with the advent of Viagra, this is the New England Journal article, and Irwin was the first author on that article. So the phones started to ring off the hook because he was first author. We didn't have emails going in those days. And who was on the phone? There were women. They weren't calling to complain that we now had a medication for men. They were calling to complain that we now had a medication for men, and what was he going to do for women? It's the first time we started talking about women's sexual dysfunction. Please understand that everything was considered a mental health problem, with the exception now we understood erectile dysfunction could have a biologic problem issue. So we put together a course which eventually became a society, the International Society for the Study of Women's Sexual Health, and that started for the first time looking at the science of women's sexual problems. That society is now 1,500 people strong. Irwin is the past president of that society. I am a past president of that society, but it really brought us into the modern day. And so that's why I wanted to have that sort of a background. Now we come into this century, the 21st century, and these are really the medications that have come through for us. Xiaflex is for people with Peyronie's disease. It's penile curvature, and it's a very effective medication, and that was approved in 2013. That same year, we had the very first medication approved for women with a sexual health problem. It is for moderate to severe dyspareunia. Dyspareunia means pain, entry pain with intercourse. We had a lot of hormones for menopause management that would go for vaginal atrophy, which is a word we no longer use. But this is the first thing specifically for dyspareunia, which is a sexual health concern. A few years later, we had prasterone, which is also for dyspareunia, for GSM, which is the fancy word genitourinary syndrome of menopause, which is how we relate to all the biologic changes that happen in your genitals and your urine and your genital urinary system with menopause.
Just before you go forward, of all the things that my experience has shown to be the home run of women with GSM or women in menopause that helps their symptoms and is safe is prasterone. It is a suppository placed into the vagina of dehydroepiandrosterone, DHEA, which is a precursor without really any side effects or problems. It turns into multiple hormones, testosterone, dihydrotestosterone, estradiol, estrone, and it's truly amazing. These things are done intracellularly. They don't get into the bloodstream, and they truly change not only the health of the vagina where the medication is presented, but because the medicine oozes out into the opening of the vagina called the vestibule, we have data documenting changes in the vestibule. So you get a 2-for-1.
We did that research study to prove that it really did help with vestibular pain when you're treating the vagina, which is remarkable.
The most amazing drug.
And while
it doesn't have a breast cancer.
That's what I was going to say, the box warning. Well, the estrogens, the estradiol medications that you put in your vagina shouldn't have a box warning on them. And ISWISH and the Menopause Society are working, trying to get that box warning removed. This is the one medication that doesn't have a box warning. It was designed by a man whose daughter had breast cancer, and he knew he couldn't save her life, but he wanted to develop a medication that women who survived breast cancer would allow them to continue to have sex, to have the intimacy. You lop off a woman's breast and you've taken her womanhood away. Now you don't allow her to have sexual relations because it's too painful. You've taken her womanhood away again. So anything we can do to help. So this is very remarkable. Then a big change was the recognition by the FDA, which is the Food and Drug Administration regulates all medications in the United States, the recognition that hypoactive sexual desire disorder was real, and it could be caused by a biologic change in the brain. So when I say HSDD, what we're saying is, imagine you're lying in bed and you're having sex and everything feels fine. And all of a sudden you realize, oh my gosh, I forgot to put the clothes in the dryer. They're going to get wrinkled. I forgot to buy milk for Janie's breakfast tomorrow morning at school, and you can't focus. Or it could be that you used to be interested when your partner walked in the room and you're ready to have sex, and now you have no interest. I mean, it's different for different people. But for the first time, we have medication. We have two different medications. One is flibanserin, which is a pill you take every night. I take it. I love it. I have no shame. As a sexuality educator, I'm very happy to talk about my sexual experience. Then bremelanotide, which is actually an injection that you use before each time you want to have sex. They make you want sex. And so restores that desire that you had when you were younger, and for whatever reason it's changed. And then the other big change in this last decade has been oral testosterone. And we're going to go into all of this later, I promise, because I know he's chomping at the bit to talk about these things more. But this is a big change, because in the old days, oral testosterones caused a lot of problems with the liver. So the modern day testosterones are very different. So Irwin's going to talk about those later. But I think the biggest change in sexual medicine is doing region-based management. I'm going to turn this over to my other half in a minute, but women and men, we saw predominantly women initially. So the International Society of Women's Sexual Health took this on as a project, but women and men around the world have this problem where they have feelings, sensations. Often it's arousal in their genitals without any actual arousal occurring there, but it can feel like burning and cutting, and I feel like a golf ball in their vagina. There are a lot of different sensations. Pain in the scrotum. There's no reason for it to be there, and nobody could figure out. And our panel put together this concept of region-based medicine, where we look at different parts of the body and rule in or rule out what could be triggering what's going on. And this is huge change. And it started with ISWISH, and we've now talked about this in sexual medicine societies around the world. So we'll go back to this. We'll go further into this. But the bottom line with this is, if you're going to your doctor because you have some weird sensations and he says, I don't see anything, it can't be anything wrong, this is the way he or she should be assessing it, through this region-based medicine. So it's a huge change just in the last 5 years in how we look at sexual medicine problems. So region 1, do you want to talk about that a little bit?
Sue, it would be my honor to talk about it. Thank you. So why don't you go back to that previous slide?
Okay, you realize we only have a few minutes.
Okay. But I mean, if we're going to talk about region-based, we have to talk about the region. So the furthest away from the brain would be the end organs, and that would be region 1. So point to that. Perfect. So of course, the male, that would be the penis, that would be the scrotum, that would be the urethra, that would be the bladder, prostate. And then for the woman, of course, that'd be the clitoris, that would be the urethra. There's a place called the vulva, and then there's the vestibule, and then the bladder also. So then we go to region 2, which is kind of that population of people who are like the bicycle riders, the triathletes, the motocross, the horse riders, where they crunch their crotch on some straddling item like a seat or a crossbar or something like that. And then region 3 is all that information has to get to the brain. So the first part in their journey is to almost the spine. It's a region called the catechoina. It's about a foot long. It starts at the sacrum and ends at the lowest rib. And there's a lot of pathology there. Traditionally, herniated discs in the lumbosacral area, or Tarlov cyst, or other explanations. Region 4 is the true spine, so from the catechoina up to the brainstem. And then finally, region 5 is the brain. So any pathology in any of these regions can cause symptoms in the genitals or the bladder or the prostate or the scrotum or the vulva. And, we traditionally get frustrated when we can't understand somebody. I'll give you an example. I had a woman today who had an inability to have intercourse because it hurt her at the opening, but she also had bladder symptoms. And during our examination, we numbed the area just at the front of the vagina called the vestibule. And lo and behold, her bladder pain went away. And just a classic sort of thing of how things share their innervation. We just had a 16, 17-year-old in the office who has this unwanted arousal. And the only thing we could find on her on MRI was, in fact, an annular tear. And she was a horse rider since she's like 4 years old. And horse riders commonly have herniated disc annular tears from the bouncing on the horse. So it's a fascinating example of how you view a symptom, but that it can occur in multiple different regions. And I think that is clearly, as Sue said, the biggest innovation is how to think of region-based management for these unwanted symptoms.
We're going to have to sort of go really quickly through these slides. So we just talked about the end organ. So this is the penis inside of vagina.
So heterosexual.
For a heterosexual relationship. So that's the end organ. Do you want to skip some of these?
No, I think they're perfect.
Okay, well, you have 30 seconds.
So the upper left slide is showing some of the vestibule pictures. The staining in the upper left picture is androgen receptors. And you could see that the lubrication glands in the vestibule that provide lubrication to women when they're sexually aroused are androgen-based. And that's a very important message, that we think women are traditionally estrogen-based, that everything about them is estrogen-based. In the upper right part of the slide, which shows the units of both estrogen and testosterone in the same unit, so that instead of them being separate.
Are you saying that women have more testosterone in them than estradiol? Are you saying women have 5 times the amount of testosterone in their body than estradiol?
Well, if you look at the slide, that's exactly what we're seeing. So testosterone is not just a male thing. It's a very important woman's thing, done in the correct dosage. I had a woman today who said, I want the testosterone, but I don't want a mustache and I don't want my voice to go low.
So I've been on testosterone for more than 30 years. Hello, close up, any mustache? And I'm a singer. I was a first soprano when I started back in my 50s, and I'm still a first soprano. So if you're taking the right dose and you monitor your hormones so that you keep everything in a safe level, there's no reason. You're returning my body to when I was before menopause, to those levels or even lower. So that's important for women to remember, that we're not putting you at a level that's like what a man would have.
So the term genitourinary syndrome of menopause, the word syndrome means signs and symptoms. To the lower left part of the slide are the signs and symptoms, and you could read them, but genital dryness, pain, not having a libido, not having an orgasm, having urinary tract infections. Those are classic, or pain during penetration. Now, the true home run of this slide is the bottom right, which shows a strategy that we use at San Diego Sexual Medicine to treat women with GSM, or the signs and symptoms of the menopause problems. On the left, we have the 3 systemic treatments: testosterone, estrogen, and progesterone, and their ideal blood test values, which you can read. But we also have, because we have chosen low values, we have to supplement them with local treatments. And there's a testosterone estrogen. Remember, it's more than estrogen alone, so it's testosterone estrogen. And then the intravaginal treatment is that home run we talked about a few minutes ago, the Intrarosa, which is the dehydroepiandrosterone suppository, which turns into 2 androgens and 2 estrogens. And it does so within the cell, so it doesn't get into the bloodstream. So menopause management is really a fabulous thing in the current era, with great success and little risk.
I think we need to stop for a minute, because a lot of people may have heard of the Women's Health Initiative, which was published a couple of decades ago. It scared a lot of people, but also scared a lot of doctors. And so they stopped putting women on these treatments, even though some of the math that was published was not correct. So the medications that were used were not the same medications as we use today. So to scare women. Instead, we wind up having women dying of heart attacks, having UTIs over and over, and urinary tract infections over and over and over because they don't have hormones, because people get scared. So some of these treatments have been around for decades, but because people stopped using them, it's really, it's more current. It's new information to be able to know that you should and you can be using these medications, that it's helpful and they're safe as long as they're monitored.
God bless you. So now we're going to talk about a new sort of awareness. So there's a medication that was brought out in the early 1990s, back to the prostate and the awareness month. The drug finasteride and dutasteride were used to help men urinate easier. These drugs shrunk the prostate. They stopped the formation of dihydrotestosterone. So you go advance one more, you can see that this drug prevented the conversion from the left side of the curve, called the substrate, to the product on the right side of the
But the
side.
problem is that this drug at one dose is for people having trouble urinating, but at another dose,
Yeah, so they found out during the usage of the medicine that the people who were on this drug could grow hair. They said, "Oh, we have a twofer." So let's now sort of challenge younger people who were balding or had families.
So the 18-year-old whose father is bald and he doesn't want to go bald, the dermatologist said, "Oh, there's no harm. You can use this." And they use it, and now they develop erectile dysfunction because, lo and behold, when you stop this 5-alpha, this conversion, you change not only what's going on in the brain, and there are a lot of different conversions, you change what is going on in the erectile tissue. And look at that.
Yeah, so erectile tissue requires, it turns out, dihydrotestosterone for the health of the smooth muscle cell. And without it, in some men, not all men, but in some men, there's a condition called apoptosis, where the smooth muscle cell turns to scarring. So that's tissue from an animal, but we see the same in humans.
So wait a minute. So if a young man gets off this because erectile dysfunction, does his function come back?
Well, in some people not. So therefore is this condition called post-finasteride syndrome, of which one of the many complaints of PFS is erectile dysfunction. And that erectile dysfunction would tend to be more permanent and irreversible. So this is a really important slide, by the way. Jeff, I hope you're looking really intently on this. So the two above and below are kind of the same. So the two left pictures are those of individuals without erectile dysfunction. Those are people who have healthy erectile tissue, and on grayscale ultrasound with a very high resolution 15.4 megahertz probe, show absolutely gray tissue, both in the left and right erectile chambers, called corpora spongiosa. If you go to the far, far right, you'll see what's called grade 3, which is a person who has extremely poor erectile function. You can see that instead of the gray, you see an awful lot of black. And black represents scar tissue, where blood can't go. Where blood can't go, you get hypoechoic echoes. And that's where the black is. And then between, you have individuals who have intermediate forms. So if you go from left to right, you can see progressive increase in the amount of scarring.
So what are some of the things that we found that we can do to help these people? Oh, the hint, it's in yellow on your slide. Can you see that? Low intensity shockwave therapy?
Well, low intensity shockwave therapy is a strategy to basically encourage regeneration of healthy tissue. If you go back to that slide, I think you skipped a tiny bit too quickly. You can treat erectile dysfunction through both a process called symptomatic treatment, where you don't change the underlying scarring, but you maximize the smooth muscle relaxation, which will help trap the blood and keep
the oral pills or the injection into the penis. That's what we're talking about, right?
Or subcutaneous bremelanotide. Now, you brought up the slide of Vyleesi or bremelanotide before under the use of HSDD or low interest in women. The fact of the matter is, it causes huge erections in men. Bremelanotide releases dopamine, and dopamine increases blood flow to the genitals, especially the penis, and they get these amazing erections that last for many hours. And it's truly more widely used in our practice, no question, for men than it is for women.
We've done that research. We did an interview trial of the men who are doing it, and it's remarkable because they get an erection and they still have this in their system, and hours later they can have an erection again. So that's a wonderful opportunity for them.
And the fourth treatment actually comes from research in Paris by a colleague who has shown us that the drug Botox, which is used to prevent wrinkles in faces by causing persistent skeletal relaxation of muscle, we have in the penis smooth muscle, and it does dramatically improve the relaxation capability. So to maximize relaxation, we have 4 bullet points there. Now, on the opposite side of symptomatic treatment is disease modification, where we get into regeneration. And that's where Sue brought up the concept of low-intensity shockwave therapy. We've done a lot of work on this. It's really an amazing therapy. It's really understudied and underutilized, but it is truly amazing. Basically, the picture above is a biopsy of a healthy penis without scarring. And as we talked about, the unscarred penis, erectile tissue, the spongy erectile tissue being not scarred, would show a grayscale that was gray. Now, the picture on the bottom shows a lot more blue, and that's the scar tissue. And that on an ultrasound would show these black spaces. And the idea here is, can we go from the blue scarred back to the healthy tissue? That would be the joy. And that would be something very exciting if that were to be done. And to do that, if you look at the farthest right-hand slide, you can see it says mesenchymal stem cell. If we can activate the progenitor cell of the penis, the thing that makes the downstream cells, through shockwave, and then make more muscle tissue, we can repopulate healthy tissue in the penis.
And we did a clinical trial.
Lo and behold,
we showed that it does work. It does help. 70% of the people in the trial had improvement. So that's pretty good. That's 70% is really what we see in all the sexual medicine treatments. So that's wonderful.
But lo and behold, you can publish and show these data. So these are animal studies, and that's the shockwave in upper left, and the bottom left shows the density of stem cells that can be improved. And go to the next thing. That's the upper left is the key. You can see in the sham, it's SHR is spontaneous hypertensive rats. You can see where they're impotent, they have erectile dysfunction, their smooth muscle presents only 29%, and collagen is 51%. You can see way more collagen.
Not a good ratio.
Yeah, but if you can change that with shockwave, which we showed you can now have 43% smooth muscle, 38% collagen, and you can show the picture, and that's regenerative tissue. That's the whole point of what shockwave does. So we have shown before and after ultrasounds where they had black spaces, and now they have gray, and it's really cool. And by the way, there's another doctor who shockwaves the beating heart, Holfeld in Austria, and he shows you can have better left ventricular ejection fraction. Another example of shockwave helping the smooth muscle grow.
Let's refocus on sexual medicine because we don't have a lot of time. And this is something we want to talk about. HF has hard flaccid syndrome. And one of the biggest problems is that it's a true physical problem, but people present to their doctor and they don't understand that they're not just body dysmorphic, that they're not just staring at their penises and think something is wrong. There actually is something wrong with the penis.
So in hard flaccid penis, as the picture on the right would show, there's a pathway that activates the hypogastric nerve. The hypogastric nerve is a sympathetic nerve, which causes the penile smooth muscle to contract, unrelenting contraction. Hyperactivity of the hypogastric nerve will cause the penis to shrivel, look like a turtle, and the end of the penis be really, really cold. And not only that, it'll make urination difficult because the bladder neck is closed. It'll make bowel movements difficult. It will raise the scrotum instead of hanging low. There's a whole bunch of physiologic outcomes. Hyperactivity of the hypogastric nerve is a real disappointing and very
painful.
It's disruptive to people's life. You always feel this unusual feeling. And it's, by the way, the only true sexual dysfunction in men that happens about the penis in the flaccid state as opposed to the erect state. So to demonstrate the temperature change, we have available forward-looking infrared. It's called FLIR.
So it's a heat camera.
And it allows you to look at the shaft, apparently, which is normal temperature. But the glands, oh my God, the glands is in the 80s, high 70 degrees. And we've done so many hard flaccid, forward-looking infrared things. I could assure you there's a dramatic difference between an HFS penis FLIR, the infrared, and that of a normal person. The glands in a normal person is in the 90-degree temperature range. Nowhere near the very cold temperatures. And when we treat the HFS with the appropriate treatments of alpha blockers, shockwave treatments, physical therapy, tadalafil on a regular basis, we have a warming medicine now that we're using. The temperature goes way up to the same as the control population.
Because you can imagine.
Actually, there's a control figure here. You look at the bottom picture, you can see the erect penis. The glands is completely normal temperature at 94 degrees.
But imagine how hard it is to live with any of these sexual problems and trying to maintain your intimacy. While it's fine to talk about intercourse versus penovaginal or genital, intercourse, people still do crave that. So
I have a comment, actually, a cute story. I was at a, I know we don't, but we have time. So I was at a lecture. And I started talking about how much fun HFS is and, how it's this novel thing we have to better understand. And the person giving the talk said, I will send you all my patients. I don't like hard flaccid patients. They confuse me. I don't get it. It's like all sexual dysfunction. You have to, as Jeff said, the key to his podcast is to provide better life quality through intimacy, better intimacy. Doing that for hard flaccid patients is another way to do that.
So I'm going to go past some of this because we don't have a lot of time. We've already talked about the end organ, but this is just briefly, these are women who have pain with intercourse and nobody can figure out why. It's because the issues that they have aren't visible. So the vestibule, if you think about the vagina and think about the labia, the place that's in the middle that sort of coaps in that you don't see, that's the vestibule. And it doesn't have a skin layer on it, but it's not really inside, it's really outside of the skin layer. And so it's susceptible to anything you might put on it that you might have an allergic reaction to. And you and I, many of us do not have allergic reactions to anything. But for someone who is susceptible to mast cell disorders, they may have a severe reaction to a medication you put on from a yeast infection or something like that. So it's just very briefly, can we just spend 30 seconds on this?
Yes, but give women due. Don't shut them down and focus on men only, okay? That's the problem with current thinking. So,
and the problem is that you can't see this when you go to a doctor. He or she can't see anything, and so they're told it's all in your head. That's medical gaslighting. The fancy word, by the way, for medical gaslighting is epistemic injustice. And so when a patient says something hurts and you can't see why it's hurting, we'll go back to the region-based medicine and figure out where that pain is coming from. But don't shut a patient down and say it's all in your head. There may be biologic causes in your brain, but if they say they have pain, they have pain. And I know that you aren't providers. You're all, the patients listening to this and learning about this. But if you're suffering from pain and your doctor doesn't listen to you, find another doctor who will, or ask him or her to investigate and learn more information.
So the condition of neuroproliferative vestibulodynia is really common, and it was only first described in 2004, so it's only 21 years old. In this tissue, it's a genetic issue. These are individuals who have many other conditions associated with aberrant mast cell activity, and that would be IBS or interstitial cystitis or asthma or Ehlers-Danlos.
There are like 22 different conditions that can be part of this.
That would be POTS, that would be GERD, that would be TMJ, there was migraines, there's a whole bunch of these.
And the majority of our patients who have neuroproliferative vestibulodynia have at least one of those other mast cell conditions.
Especially endometriosis, where we see a very common overlay. Now, for reasons unclear, the tissue of the vestibule is infiltrated with these mast cells, and these are live, metabolically active mast cells. They release nerve growth factor constantly within the vestibule with the subsequent deposition of excess number of nociceptors or nerve endings in the vestibule. And if you have too many nerve endings, and all you do, I take my hand here and just tickle the skin surface, but if instead of having the correct number of nerve endings, they have excess nerve endings from the excess mast cells, and you tickle their tissue, they scream when you touch this thing. We just take a Q-tip and just tickle their skin, and they go like this with their face. It's such an awful condition.
So if you cut yourself, the nerves would come to heal, and then the nerves go away. But for whatever reason, once these nerves come, the mast cells come, they never go away. And so the pain that women experience, they can't wear tight pants. It hurts to have any kind of penetration, whether that be a tampon or sex play. But it's really devastating. It can destroy self-esteem, and it can destroy relationships.
There's two kinds of stories with this condition. As you can see in the upper right, it says congenital. These are people who have it all their lives. They can't put a tampon in. They can't have a speculum exam. They can't have fingers placed. They can't have penises placed. They can't have dilators placed or sex toys placed because it just hurts. Now there's another group, and I saw a patient today. She had a yeast infection, and she took a drug over the counter called Monistat, and the Monistat caused severe burning, and that burning has never left this woman. She's 6 years of severe burning. And this is this condition of too many nerves in the vestibule called neuroproliferative vestibulodynia. Again, it's a 21-year-old condition for which we are learning more and more about, but a very common condition. And we now have more than 80% success in managing this, which is truly, truly amazing.
And I'm clearly not having success in managing the slides because I think our time is up. So I'm hoping that Jeff will let us keep going and do some more.
Jeff, let us keep going. It's all your fault.
So these are some of the mast cell conditions that we talked about. So we can go past that. We've talked about where region 2 is. I think we're going to skip to region 2. Are you okay with that? Because I'd like to get to some of the other things. High tone pelvic floor is region 2, but there are so many things. It could be your physical therapist can help you. You maybe need a nerve stimulator. Maybe you need a Botox injection. Maybe you need pendental nerve entrapment surgery. A lot of things going on. But what we would say with the region-based management is, what is causing the high tone pelvic floor? Is there something else that's triggering it so that no matter how many times you go to physical therapy, that trigger is still there? Let's remove the trigger and then go back to physical therapy and relax those muscles. But there are a lot of different things going on, and you really need your provider to use those region-based management strategies to figure out what's going on so they can determine what's the best thing to help you. But we've learned so much more about all of this over the last few years. Can we skip this?
No.
See, he's forcing me.
So we passed quickly through. We spent reasonable time in region 1. That's what you can see with your during your exam. Region 2, we spent somewhat of a time where you can actually examine. But region 3 is kind of hidden. It's in the lower back area, and we've all heard of the term sciatica. So sciatica is when you have low back pain. Typically, a herniated disc is the genesis, but there's pain shooting down the leg. There's nothing wrong with the leg, and you can't walk on your feet or toes, or the back of your calf hurts or whatever. That's called sciatica. But sciatica is understood where there's nothing wrong with the leg, but the genesis of the problem is in the lower back area. Well, instead of lower extremity sciatica, you can have penis sciatica, you can have scrotum sciatica, you can have clitoral sciatica, you can have vulvar sciatica, and you have vestibular sciatica. It's the same concept. You can have pain in a region where the true genesis is the lower back. And I'm just telling you, we see this over and over and over again. And God bless America, we have found a spine surgeon. We've done over 200 surgeries on patients with a genitopelvic sciatica, who concomitantly may have also lower extremity sciatica.
So I'm going to pull a call out there. If any of you find a spine surgeon willing to do surgery for someone with a sexual health problem rather than a back problem or a leg problem, please let us know, because our patients come from around the world. And right now, the only surgeon we know is Dr. Chol Kim at Excel Spine. Give him a shout out because he's wonderful. But if you know somebody, let Jeff know and he'll let us know. Can we just...
So just the point is that the upper two slides show a break in the annulus where the internal blue, which is called the nucleus pulposus, escapes, and it puts pressure on the nerve roots, causing the sciatica. That's basically what we're trying to show here.
So they suck out that annulus that's causing the problem.
Well, the surgery will then suck out.
We don't. Spine surgeon does.
And they don't even go into the hospital. It's all considered outpatient.
They go home with a bandage on them that day.
The surgery is through an endoscope.
Okay, we're going to jump ahead.
Yeah, let's do
region 5.
Although, just to be honest, today or yesterday on Monday, we had a region 4 sexual medicine program. Talk about brand new stuff. This is a diagnosis called tethered cord syndrome. Tethered cord syndrome, where the spinal cord is under stretch by the filum terminale, the end of the spinal cord that attaches to the coccyx, is so tight and so sclerotic that actually brings the spinal cord down. So the brainstem is lower, and the end of the spinal cord, called the conus medullaris, or the sacral spinal cord, is lower on the MRI.
So talk about what's new in sexual medicine. This surgery yesterday says the only second time in history that we're aware of in the United States that this tethered cord surgery has been performed for a sexual health problem. So that is really
she has
phenomenal.
Low back pain, she has urinary incontinence, she has sciatica, but she has persistent genital arousal disorder. That's where we get involved.
And since her surgery, has she had any flare of the PGAD?
She has not, which is so freaking amazing. Yeah,
That's you, Dr. Petra Kling.
Okay, she's the surgeon at Brown University.
Yes.
All right, so region 5. So we're now into the brain. We've passed through the regions. We could give you a 4-hour lecture. Apparently, we're not able to do that. But in the brain is this condition where you treat depression, anxiety, PTSD, OCD, and other mental health conditions.
NHSDD, which is not a mental health condition, it's a sexual health condition.
With these medicines called selective serotonin reuptake inhibitors, or SNRIs, and they're recognized to have less suicide, and they have great benefit. However, if you want to read this slide very slowly and carefully, you'll know that these medicines, sadly, have the ability to change the sort of integrity of the nerve, the structure of the nerve. They can change the structure of the synapses. That's when the nerve ends and another nerve starts. They can change the ability to synthesize the neurotransmitters, dopamine, glutamate, and GABA. They can be involved in modification of receptor structures. They can be involved in all types of things.
So are you saying,
so sad.
So we know when these are prescribed that they cause sexual problems, and the doctor will say this will cause a sexual problem, but when you stop it, everything will return to normal. Are you saying that there's damage in the brain and things do not necessarily return to normal?
I love the setup. Yes, these things apparently can't persist. And God knows how many patients we see with this, but it's way too many. It's called persistent, SSRI-associated sexual dysfunction, and the acronym is PSSD, and it's a disaster problem.
In Europe, the EMA, which is their equivalent to the FDA, has declared that these problems can exist, that PSSD is real and can occur from these medications, but we're not there in this country yet. So hopefully someday there'll be more knowledge, but this really is important to know. Okay, now we're gonna jump ahead to, we're just talking about region 5. So hypogonadism is having low testosterone, and you don't treat for just low blood tests. You treat for people who've low blood tests and symptoms, correct?
Correct. So this is called hypogonadism, a really common problem. We can argue, we've talked to you earlier about menopause in women, which is the
most common problem there is for women.
Well, and after reproductive age is ended, like in the early 50s until the 80s or more, depending how long people live. But the ovary traditionally in menopause stops functioning. That's different in men, where the testicle continues to function, but it doesn't continue to function at the exact efficient rate. So there is a sort of a decade reduction of the ability to synthesize testosterone. So instead of the abrupt GSM version in women, there's this slow progressive reduction in synthesis of testosterone for men. So it's a little less obvious, the menopause that we're seeing in men who have these symptoms of low sex steroid hormone, in women estrogen and testosterone, and in men the testosterone. So there have been studies in the early 40s, 1940s.
Before any of us were born, early 1940s?
Sort of
Even I'm not that
World
old.
War II, where for the first time in history, testosterone was synthesized. And everybody wanted oral, and oral came out, but it sort of caused problems in the liver. So it got dropped, and the only original values in the 40s and 50s were pellets and injections. And that sort of stayed that way till about the 80s, when a plethora of delivery systems were developed, from patches to gels to creams to solutions to things that go in the nose, et cetera, et cetera.
So there are a lot of options available. And the reality is that for a lot of people, they're going to choose the option that their insurance company is going to support. Or if they have no money, then they're going to go back with the injectables because that is the cheapest. But we have this wonderful new option.
Yes, open your mouth and swallow. And it does not involve liver damage. In fact, in this very ironic way, it actually improves liver health, and we have lots of data to show that. And one of the things that it does, if you look at this slide, one of these things talks about sex hormone binding globulin, which is liver protein. And it actually is the first drug in the history of Earth that reliably lowers SHBG. And if you can lower SHBG, you can increase the free testosterone. And if you increase the free testosterone, you increase the synthesis of dihydrotestosterone.
Let's just break that down a little bit. So SHBG is like a baseball mitt ready to catch the ball that's shaped perfectly in there. And what is that ball? It's testosterone. And once it catches that testosterone, it doesn't let it go, which means that testosterone is not going to do anything to help your body. The only testosterone that helps your body is the free testosterone, whatever isn't bound to the SHBG. So if you have a high SHBG, you're not going to have a lot of free testosterone available. But if you have a low SHBG, so if this drug can actually lower what it is, make it even better, then you're going to have more testosterone available for your body to do its thing in your body.
Yeah, and it's done by oral. You don't have to stick a goddamn needle in your every week or twice a week.
Not that there's anything wrong with that if that's your choice.
You don't transfer the gel to your partner.
Again, not that there's anything wrong with it if that's what works for you.
And it mimics reality. During the man's life, prior to him needing hypogonadism treatment, there's what's called diurnal variation of testosterone. It goes up and it goes down every day.
Morning and night.
So this medicine does that too.
Because you take it in the morning and you take it at night.
And there's way less side effects of high hematocrit because of that. And we believe that it doesn't turn the gonadotropins, FSH and LH, into zero.
Can you explain that into English?
Yeah, that's important.
Matters?
That's important because if you're providing through injections and there's very high values of testosterone for long periods of time, you're going to suppress the traditional sort of stimulation of the testicle by these chemicals called LH and FSH.
So what does that do to the testicles?
So without LH and FSH, as one would happen on injections classically, the testicles will shrivel. They turn into sort of raisin nuts.
So if you're a young man, would it be smart to use the testosterone that's injectable?
I love your question. You're too funny.
We're trying to educate our audience here.
So you would use medicines that actually activate the gonadotropins, and that would be clomiphene citrate, or N-clomiphene now is very popular.
Which are off-label, by the way, so your insurance is not going to pay for it.
Yeah, and HCG.
But that's only if you're young and you want to maintain your fertility. So if you're already past that, then the oral drugs are not going to affect the LH and FSH.
And one more comment. What's new? This is prostate cancer awareness. So linking it back to that, there was once a great fear, as there was in gynecology, of giving estrogen causing breast cancer. There was once a great fear of causing prostate cancer in men giving testosterone, and that has disappeared. Abraham Morgenthaler, God bless his soul, well, not his soul, he's alive and well, but God bless him and his soul, has done amazing work to convince all of us that, in fact, once you have a certain amount of testosterone that has stimulated a certain amount of the receptors in the prostate, once you achieve that, adding more testosterone to raise it from like 300 to 800 won't have any influence on the growth of the prostate.
And
that's huge.
Do you know that all of the hoopla about prostate cancer coming from testosterone comes from 2 case studies in the 1950s, and one of them, he wasn't even on testosterone or something. So it's hype from a single case that the reporters, ran with it in the newspaper. And then how many physicians, how many of your doctors get their medical information from the newspaper, or now it's social media rather than, learning it. So a lot of information gets magnified, blown out of proportion. The same thing for as you said, the WHI for women. And so part of what we want to be involved with people that bring the language, bring the science back to reality, so that you can be comfortable safely taking
take-home message. Oral testosterone is the way to go.
Now, what's new in sexual medicine, which is what we're supposed to be talking about the whole time, but we're really talking what's newish. There are several companies working on topical applications for erectile dysfunction. There's one company that actually made a topical application. They tested, this is really strange, they tested the vehicle, which is like the cream it's in, the gel it's in, with the gel with the actual medication, and they found the gel itself improved erectile dysfunction. We have other companies that are working on topical applications for erectile dysfunction. And you also briefly mentioned a company that's working on a topical application for hard flaccid syndrome. Now, on the female side, Dare to Play is a product that's actually going to be coming out very soon. I'm excited because we did a lot of the initial clinical trials. And what it does is it's a topical application of sildenafil, which is generic Viagra, but in a special formulation that will actually penetrate the skin, so that women experienced increased arousal, but they felt the arousal in their brain, which is female cognitive arousal disorder, the FCAD, and felt it, and it was experienced in their genitals. And how do we know? Because we did the heat camera, the thermography, and showed that it had improvement. That's female genital arousal disorder. Do you want to? I think we don't need to really talk about that.
I think the bottom line is sildenafil has been widely used in men, and we are so optimistic that with this new formulation, the Dare to Play formulation, we'll get this very large molecule easily through the skin surface of both the vagina and clitoris, and add to the experience of improved arousal to improve their intimacy for women. And that's very optimistic. We have data to support it, and we think great things about it.
So that's the data to support it. And the thing is that we do know that the 2 medications for women, the flibanserin and the bremelanotide, Addie and Vyleesi, the trade names, do also improve arousal and orgasm for women. And because we've seen it in men and tested in men, it also improves it in men. But this is the first treatment for arousal. It's actually going to be a compounded medication until they get it through the FDA. It will be available towards the end of this calendar year. So it's kind of cool that's a brand new on the horizon. But I know it's time to take it home. So do you want to do your take-home messages and I'll do mine?
Yeah, I think, why don't you start? You're the woman.
Well, then I'll just do all of them because I'm the woman. There's new ways of diagnosing sexual health concerns is really key. Irwin and I have been lucky enough to be asked to speak in various places around the world, various meetings, and we've been spreading this word because we're both on that original committee that wrote that paper. And we're excited that there are new treatments that we're currently using for sexual health concerns, some on label, some off label, and that there are new treatments that are on the horizon. But my message is always, just because your doctor doesn't see what's wrong doesn't mean it's not real. You believe in yourself. Don't ever doubt yourself. If you're feeling something and the doctor doesn't see it, the nurse practitioner, the physician assistant doesn't see it, don't doubt yourself. Don't be afraid to ask your provider for help, because the reality is that the majority of clinicians are afraid to open the door and start the conversation with you about your sexual health, because they're not comfortable talking about it or they're afraid of embarrassing you. And the majority of patients don't start that conversation. There is literature on this, there's research. The majority of patients don't start the conversation because they're afraid of embarrassing their doctor. The reality is, if you need help, don't ever be afraid to ask for help. And if your doctor can say something very simple, that's a great question, Mary, John, whatever. Let's make another appointment to talk about it. Or that's a great question. I don't know about it. Let me research it. Or that's a great question. I don't know about it. Let me refer you. But don't ever take the answer from a doctor that says, no, there's nothing that can be done. Because even if we don't know what to do today, you saw the field of sexual medicine is still so brand new. If we don't know what to do today, maybe by tomorrow we will.
Amen. Jeff, take it away.
Thank you for having us.
No, thank you. Awesome. Gosh, so many great things that you covered, and so many exciting, novel, new things, as well as things that have come about over the last couple decades that are just wonderful. One of the things I was thinking so much about was the menopause management. And you think, my gosh, the GSM, this has been, I don't know about your practice, but I think even in my own life and with my friends, I think either you have women who are addressing and treating it or women who need to address and treat it. It seems like just about everybody will experience that vaginal dryness, that discomfort, that challenge of GSM. There's no doubt about it. It's so prominent and so prevalent. And I'm so excited that we have other ways of treating, especially for people who are concerned about breast cancer, different things like that. There's so many safe ways to treat this. I remember one of my patients was so frustrated because she was on tamoxifen and everything. And she was just like, I can't live like this. It's like, I want to be a wife. I want to be a woman. It feels like a knife going into my vagina when I try to have penetrative sex. I can't live like this. This is not okay. And you shouldn't have to live like that, right? Because the local therapies have been shown to, when they're strictly local, have been shown to be helpful in breast cancer patients and safe, as well as the prostaglandin and the ospemifene as well. There are treatment options that are safe and effective for just, this is such a treatable problem, right?
Yes, people need to talk about it. One of the problems we have is that women don't talk to each other about what they're going through. And because when your menopause happens, you have your hot flashes and all the other vasomotor symptoms. But typically the symptoms of dryness and pain don't occur till maybe 5, 6, 7 years after you've stopped menstruating. And so women don't associate that with menopause. They just say, oh, this is just happening. It's part of aging. Well, even if it were part of aging, that doesn't mean you have to accept it. Somebody asked me, what's the oldest you can be and still have sex? I said, as long as you're alive, you can still have sex.
I forgot to say, and I so agree with you. And I think everything you're saying is absolutely true. I wanted to say too, and I forgot right before as you finished, I wanted to first say, wow. You two are like the perfect team to present together, because you got that educator mind, Sue, where you're always a step ahead thinking, make sure they get this, make sure they don't miss that, bringing it down to earth. And you've got your brilliant mind, Irwin, that's just, there's so many things going on and so many excellent discoveries that you've made and that you've been involved with. So I wanted to say, oh my gosh, you two are like the perfect presenter team. So thank you.
Your podcast the goal of your podcast is to improve life quality through better intimacy. How perfect a goal. God bless you for.
We need more information.
So we're number 39. Is that the deal?
Yes, you're number 39. So definitely, and so it's very exciting. But I mean, such great information, so many things we could talk all night about, but and all those new discoveries. And I think too, but I think things like, one other thing I wanted to bring up and make sure people know, like, for example, the shockwave therapy. We know there's a lot of people out there doing shockwave therapy. And what people have to understand is the importance of making sure you go to places that have the right equipment, the scientifically proven equipment to help you, the protocols that have been shown to help you, so that you get the help you need and not basically sham because they're not using the right things. And so there's lots of people out there who want your money, lots of industries out there that want our desperate sexual health patients' money. And that's such a sad thing we see in our clinics every day. But there are wonderful providers who can provide scientific-based protocols like that shockwave therapy, the proper way, used along with some of the traditional therapies to really change your world when it comes to sexual function. So I wanted to bring that point up too, because that's
Thank you
so
much
important.
for saying that, Jeff, because there are so many scam artists out there, and patients call all the time, and they'll say to us, because they know we have the shockwave, they know we have the soft wave device, which has a lot of literature for it.
I've sent you patients to California. I've sent my patients to California to you because to make sure they got the right treatment.
People will call us and say, does Dr. So-and-so have the same machine as you? And it's like, well, I don't know. You'll have to call that doctor's office. How would we know? But you're right. There are machines that are actually, it's called radioballistic, and it works by pounding. And it's wonderful. Those are wonderful for physical therapists because they're providing muscle relaxation. The regular shockwaves can also provide muscle relaxation, but it's not done through pounding. And so it's, as you said, it turns on the mesenchymal stem cells that live in that area, which allows them to work and do their thing. So it's really important for patients to do their homework. One of the things I always say is people spend more time shopping for a used car than shopping for a doctor. They go to the one down the street because it's convenient, who may be wonderful and may not be. So do yourself a favor and, research the person you're going to. It doesn't matter, man, woman. It doesn't matter if they're an MD, a DO, an NP, a PA. There are wonderful providers and there are terrible providers. And you owe yourself the best homework, to do the best homework before you go and get help.
Right. And people can go to the Sexual Medicine Society of North America, of which we're both members and going to be together in less than 2 weeks, and find providers there. They have a provider button there and you can find a provider. So those urologists, those healthcare professionals who are dedicated to sexual medicine, who have the right equipment, are going to do the right protocols, and ask. Make sure, look up the studies and see, this is what my expectations are. I think I should have it done this way, but I think it can be really helpful. I do have this one. I thought this was a really good question. I'd like to feed you this first question, which was, even when some treatments failed, Dr. Albaugh encouraged us to keep working on intimacy, which was helpful. What role does hope play in sexual medicine? I thought that was an awesome question from a listener.
I love that, because we all know that your mental focus plays a huge role. We see it in cancer survivors, that people who have a positive attitude have a much better outcome than people with a negative attitude. And I think it's the same thing. I'm among the many things I do in our office, I also am the surgery scheduler. So I spend a lot of time especially with these young women who have neuroproliferative vestibulodynia. I really believe the women who go in with the attitude is, I'm going to get this tissue taken out, I'm going to be great and have the best, have the rest of my life. I think they heal more, well, I don't know if they heal more quickly, but I think they do better. But I mean, hope allows you to go into everything you're doing with a positive attitude and allows you to open your eyes and seek practices like San Diego Sexual Medicine, where somebody can help you. What are your thoughts?
I think we should develop a hope questionnaire and a hope Likert scale and test the hypothesis. I think that would be very cool. I mean,
that's a great study. That's a great study.
That being optimistic and being open is way better than being like the opposite. And but we can test that hypothesis and develop this questionnaire. Let's do this, Jeff. God bless you.
Is smiling and laughter considered the best medicine you could take, having that positive outlook?
Yeah, gratitude. We've talked about on the show gratitude and how powerful gratitude and how it changes your life. So I think there's so many things that could be done. And I guess listeners, gosh, you can already see this couple literally. Do you feel like they just want to jump out of the screen and help you? Because they do. So I can't thank you enough. We could go on forever. I just want to do our closing exercise and then close out. So I know that this was a lot of information, and you've just heard some exciting news about new treatments, possibilities on the horizon. Okay, like we always do in this show, towards the end, let's take a moment to gently come back to your center and to reconnect with your true miraculous self. If it feels comfortable, close your eyes. Begin by breathing into this moment, slowly inhaling through your nose Feeling your lungs and chest expand and exhaling fully through your mouth, letting go of any tension. In through your nose, out through your mouth. About 4 to 5 counts in, about 5 to 6 counts out. Keep breathing that pattern. And as you breathe, bring your awareness into your body, your breath, your heartbeat, and the simple gift of being alive in this very moment. Remember, sexual health is not just about treatment or function. It's about wholeness, intimacy, connection. As you continue to breathe deeply, allow these affirmations to settle into your body and your beautiful spirit. My true self is whole and complete. My true self is whole and complete. I am more than any illness, challenge, or condition. I am more than any illness, challenge, or condition. I am inherently worthy of love, intimacy, and joy. I am inherently worthy of love, intimacy, and joy. Take a moment to honor all that your body does for you each day and to welcome the possibility of new beginnings on your own journey of intimacy. When you feel ready, gently open your eyes and carry forward with you this sense of curiosity, compassion, and hope into your day. Well, I cannot thank my guests enough. Sue and Irwin Goldstein, I can't think of anybody better to have on the show. I thank you wholeheartedly. Vic, what's up next week on Dr. Jeff Talks About Sex and Intimacy?
Perimenopause can feel like a roller coaster, physically, emotionally, and sexually. In this candid and compassionate conversation, Dr. Susan Kellogg-Spatt, renowned pelvic health and sexual medicine expert, will unpack the often misunderstood journey of perimenopause. Dr. Kellogg will explore the hormonal shifts, mood changes, sleep disturbances, vaginal dryness, and libido fluctuations that can show up during this transition. With practical advice and a message of empowerment, this episode helps listeners better understand their bodies, communicate their needs, and embrace midlife as a time of possibility, not decline. Join us on October 7th at 7 p.m. Central Time to learn more.
Wow, what an amazing scientific-based episode. You couldn't have asked for better, and you two are you're phenomenal together. I'm so glad you came on the screen together. I love the synergy between you. I can't think of anybody better to educate than the two of you, so thank you, thank you, thank you.
Thank you back, Jeff.
Thank you for having us.
Great to see you again.
Thank you, listeners, and our hope and prayer is that you find all you're looking for in your journey and that you have more love and more intimacy in your life. Thank you.